Hi. Hello, everybody. Welcome to Knock Knock Hi with the Glockenfleckens. I am Will Flannery, also known as Dr. Glockenflecken.
I am Kristen Flannery, also known as Lady Glockenflecken.
It's New Year's Eve.
Woo-woo!
Happy New Year to everybody. And how do you feel about, where are you with New Year's Eve festivities at this point in your life?
You know.
Yep. That sums it up. That's about right. Yeah. It's kind of like, okay. Like
regret and shame that I am now too old to stay up comfortably till midnight.
It is not regret or shame for me. I could not care less about staying up till midnight. In fact, I love being on the West Coast because you can put the TV on, you can watch the ball drop at 9 p.m. with the kids. They're not young enough that we can trick them into thinking
they know what time it is.
They know what time it is. But that was a good few years though.
That was.
Right?
We would do like 6 p.m. Or sometimes I would even do, when they were really, really little, I would do noon because that's 12 o'clock.
Yeah.
They don't know the difference. They don't know it's supposed to be nighttime 12 o'clock.
Would you be interested in doing like an adult, like like a festivity thing, like go somewhere? We've done that before.
Yeah, look, New Year's Eve used to be my favorite holiday because it was so fun. Like everybody's just happy on New Year's Eve. You know, if you're out, everybody that made it out is happy.
Everybody's drunk and making out.
Yeah, and it just feels like a time that's hopeful, and I don't know. It just feels, even though it's just a big mass delusion, right? Like it's just another day, but it just feels happy and fun. And so I used to love it, but now I can't stay up that late. I don't like to deal with crowds. I don't want to find parking, and I don't want to wear uncomfortable shoes. So.
Wow. Yeah. We'll see. And just know what you want at 40.
That's right. It is what it is. I would love to have everyone come over though. Like have people come to me. Sure.
People come in and then they all go home by 10 p.m.
Yeah. Perfect. Sounds ideal.
So that's our, but now that the kids, like we have to stay up now.
We do, and we're starting to enter the years. We're not quite there yet, but we're very close where we have to stay up because we don't know what they might be getting into. Like we don't know what they're up to. So we got to be awake to make sure they make it home and whatever. So
the mischief level,
is going to increase very soon.
We got a 9 and a 12-year-old. So
yeah, but see, that's why I like to try to be the house where people want to come over.
Yes,
because then you don't have to worry about all that. Everyone is there, and you.
So that is key. Like I had that growing up.
Yeah.
And part of that's because my parents did make an effort to like make it a place that people that my friends felt comfortable being at.
Right. There was a lot of bribery happening. Exactly. Banana milkshakes.
Like that's how you do it. Yeah. Lots of game nights, video games, board game stuff, and I think that's what they were doing. I didn't realize it at the time.
Yeah.
But I think that's such a good thing to like be the house.
Yeah.
Because you know where your kids are,
right.
And you can keep their kids' friends and their parents.
You can keep everybody safe.
Yeah. It's so anyway.
Especially, because you don't always know the kids' parents either. Like you don't know where they are and who they're around and who's looking after them. And maybe we're just two very controlling people.
You're describing your ideal New Year's and then the fact that you don't trust anybody outside of our home. We go to the grocery store at 2:00 in the morning, everyone, to avoid, it's, we're sounding like hermits.
I know. I think we're just getting old. Whatever. It is what it is. Does
anybody relate to this? Tell us what you're... As you have gotten older, you, the listener, the viewer on YouTube, how has your attitude toward New Year's changed? I'd love to hear if we're the only ones, and like as we approach 40, you are already 40. I am almost there. Is there any still excitement about New Year's out there, like for people over the age of 40? Like what?
You know what? For me, it's more like, oh man, I just got used to it being this year, and now I have to remember that it's a different one. And sometimes I'll still find myself slipping up and putting like 2003 on like in the rare occurrence that I have to write a check or something.
We need to take you to the doctor. I think.
know.
I think there's something
something's not right. I think there's a lot of things not quite right up there.
Let's get to our guest, shall
we? All right,
we?
let's do.
All right.
Speaking of me not being quite right.
Right. We put Kristen.
Guest.
We put Kristen through a lot.
Well, no, the guest is lovely.
The guest is great.
The topic matter I struggled with.
There's some ophthalmology talk today, and we all know how Kristen feels about eyeballs. Same way I feel about teeth. But we talked to Dr. Andrew Lamb, is a fellow ophthalmologist, retina specialist. He's a retina surgeon affiliated with Bay State Medical Center in Springfield, Mass., and assistant professor at the University of Massachusetts Medical School. Also, an author. He has a couple of books. He has a new book called Masters of Medicine. We talk a little bit about that. And also a book called Saving Sight, where he tells stories about growing up in ophthalmology, like becoming a surgeon, his upbringing, things like that. Great books, great writer, great storyteller. We talk about some harrowing adventures in ophthalmology.
Yes.
Which
I almost had my own harrowing adventure, but I made it. I am here.
Almost passed out over here. If that convinces you to watch or listen to the episode. So let's get to it, shall we?
Let's go.
Here he is, Dr. Andrew Lamb. Today's episode is brought to you by DAX Copilot from Microsoft. To learn about how DAX Copilot can help you reduce burnout and restore the joy of practicing medicine, visit aka.ms/knock-knock-hi. That's aka.ms/knock-knock-hi. All right, we are here with Dr. Andrew Lamb, a fellow ophthalmologist. Thank you so much for joining us.
Thanks for having me. Appreciate it.
Yeah, so it's always a pleasure. You know, the last guest we talked to was a dentist, which is very outside my wheelhouse, and so I feel like a warm blanket.
This is your comfort zone.
Now I'm in my comfort zone,
happy place,
with talking with an ophthalmologist. So I'm excited.
That's good.
About
I'm glad to be talking to you guys for sure. I've learned that every field is very important. I used to think, rheumatologists weren't that important, weren't as valuable a field until I saw a patient with a rheumatology problem, and that's exactly the most important thing to them. And same with dentistry, I'm sure. But I'm just love to talk ophthalmology.
It's funny you say that, because there's a surprising amount of overlap between ophthalmology and lots of different fields in medicine. People don't realize that because we are very much in our own little world. But like a lot
would you say you're in your own orbit?
Oh man, you're already starting in with the puns. That's good. But like rheumatology, dermatology, like all these autoimmune diseases, I'm sure you as a retina specialist, because I hear there are some inflammatory things in the back of the eye. I don't know. That's just sometimes a rumor that me as a
That's why they view you as a specialist, right?
That's right.
Yeah.
That occasionally we do overlap with other specialties.
Here's what I know about him as a retina specialist. Is I already know that he's much smarter than you.
Oh, I don't. Well, yeah, probably.
Yeah.
Yes. Well, it depends on smarter about what, because he did decide to do 2 additional years of training, and I wouldn't want to wish that on anybody.
Yeah, that is debatable whether that was a smart decision, I guess.
I do remember my wife and I told her, I broke it to her. I was like, I think I want to do retina. And she's like, oh, that might be a little demanding, a little hard. And then for a while, I was like, what if I did medical retina? And I tried to. She also, for some reason, didn't think that was going to be that worth it. And so, in the end, I just had to follow my heart, I guess, and it's worked out.
Well, let me ask you this: when you reattach the retina, does it make a zipper sound? Is that true? Is it kind of zip?
There are definitely sounds, but we're so much more focused on can we see. I can't tell you how many times we're trying to fix retinas and we can't see what we're doing. And so it's kind of like we're using the force. I used to follow my attendings and I'd be like, I can't see what you're doing. How do you know what you're doing? And I'm like, are you using the force? Yeah.
This is actually news to me, because so when you're doing, let's talk about retina surgery, because this is, actually let's step back and just, let's say, a lot of people get confused about this because the eye is such a small organ that it's shocking to people that there are 7, 8 different subspecialties,
fellowships.
7 different fellowships you can do just within ophthalmology.
Yeah.
You just pick a part of the eye and you can do like 1 to 2 years of additional training.
That
just
does
learning
seem
about
odd.
Yeah, It's a great field. Yeah, you can, all the things that all these people, when they go to med school, they say, I want to do these things. I want to have long-term patient relationships. I want to work with kids. I want to like do pathology. All of that is possible. I want to do surgery in ophthalmology, and depends on what field you go into. So,
and so I did residency, and I was done. I was like, I didn't like any one thing enough to do it all the time, right? I was just so bored by the end of every single subspecialty rotation I did that I was like, all right, maybe that's the universe telling me that I should be a comprehensive ophthalmologist. And so, but I remember what it was like to learn cataract surgery, and you do too, obviously.
Oh yeah.
Stepwise, you do like just a little bit at a time, get all the different, you practice inserting the lens, and then you do the rexus, and then you do the incision, and you're kind of stepwise doing it. Is it the same way with learning retina surgery? Because in my mind, I didn't do any retina surgery as a resident, so if I had gone to do a fellowship in retina, I feel like it would have been starting all over to a certain extent.
Yeah. We did not do a lot of retina cases as residents. We might like pass some scleral buccal sutures or something, but they're not going to let you into the eye, the inner sanctum, basically.
Right.
But I agree. Cataract surgery, I remember feeling like super confident when I went into it because I had seen it done as you have many dozens of times, and it seems so efficient and elegant in 5 minutes, And I remember trying to like do the rexus. I'm like, oh my God, this is like invisible. Well, of course it's invisible. You have to see through it, right?
Right.
And so it was definitely like challenging, but then you learn little by little and you get better and better. And retina surgery training is like that, except the stakes are a bit higher because like you're trying to peel the internal limiting membrane in a macular hole surgery, for example. But unlike if I mess up the rexus, my attending could like just bail me out, or do can opener, and then I mess up the can opener, and then he like just comes and bails me out. If you ding the retina,
the cataract, it's Kristen's
I've
looking
got
at me
no
like,
idea
what is a can opener?
Any of this means.
Can opener is like for the people who mess up the beautiful smooth rexus, like your husband's been doing. Like,
what's a rexus?
The rexus. So the lens in the eye is like a peanut M&M.
Okay.
And doing the rexus is like removing the candy coating on the top, so you can get into the cataract. And you want it to be a nice
chocolate and the peanut.
Yeah, gotcha. You want it to be a nice round circle, but if you screw it up, sometimes it's not a nice round circle, and your attending has to save you.
I see.
Yeah,
okay.
Yeah, but he's talking about
a lot of in retina surgery, you do a lot of tentative. If you're a conscientious trainee, you're just being very cautious. Which is why I have so much respect for my, attendings and mentors, because it must be heart-stopping to watch these trainees like you and I were learn, right? Because you have the responsibility, and we might mess up, and at the very minimum, it takes forever, right? You're waiting and waiting for this guy to like do something.
It sort of reminds me of like if you're a parent teaching a teenager to drive, right? And they're in your car.
Oh, that's torture. Yeah.
And you are trying to be instructive and encouraging, but also going every 4 seconds.
We haven't gotten there yet in our parenting journey.
I've taught 3 kids to drive. It was torture.
Which do you think is worse, teaching a kid to drive or being an attending to a resident learning eye surgery?
Well, there were a few times when I grabbed the wheel of my daughter. So I've never had to grab a trainee's vitrector. But the worst, absolute worst moment as a parent is when your oldest kid drives away with the rest of the kids in your car, and you and your wife or your spouse are watching them drive away.
Yeah.
There's nothing quite like that in surgery.
Right. Because it's like, I guess it'd be like, as soon as the ILM peel starts happening, you walk out of the operating room, which you would never do.
Right. Totally unsupervised, I guess. Yeah.
In the ILM, so he's talking about peeling. This is a relatively common. It's a common surgery for them, but how thick is that tissue you're pulling off of the retina?
We're talking like 10 microns or less. If the macula is like 250 microns, it's very, very gossamer. Yeah.
Yeah.
That's why we get to say we're neurosurgeons, because we're working on neural tissue that's connected to the brain.
Yeah, technically. All right.
Yeah.
All right, that's a stretch.
Yeah. So let's go back a little bit and talk about your training, because you went to Wills for residency. So Wills Eye Hospital is one of the most famous eye hospitals. It's in Philadelphia. I interviewed there I was very fortunate to get an interview at Will's. I was very excited about it. And it was the first time I had ever seen an eye emergency room.
Yeah.
Tell the people about that, because that's a very strange, unique thing that only a few places around the country have.
Yeah, Will's is great. I was really lucky to train there, and they have an emergency room just dedicated to eyes. So you can imagine there's a few places in the country that might have that, and it basically becomes a huge dumping ground for everyone's eye problems around the tri-state area or the area. Like as an ophthalmologist,
right.
In the area, or even an emergency care doctor, you must love it, because you just like, oh, there's an eye problem, just go to Will's, essentially. But
it's there. It's open all the time.
Yeah, like why should I even bother learning how to look at someone's eye? I could just send you right there. So, but it was great as a resident, obviously, because you literally see everything. Every time you're on call, it was one of those things where it was like, oh, it was the busiest, it was the most stressful, but also was the most learning. So we all enjoyed it. And we all liked it a lot. So it was, just everything under the sun. There's a book called the Will's Eye Manual, which is kind of like very popular. And
I still use it. We have them in our clinic.
It was written by the residents back in the 90s, I think. That was the first edition, just because of all the things that came through that ER. And then when I was a resident, I basically realized that after a few months, I've seen almost so many things in that manual, and I felt like it was really lucky to kind of just have all that experience, of course.
Who was staffing it? So you had residents.
So when
there?
I was there back in the olden days, this was before the 80-hour work rule, and a lot of other supervision was occurring.
Yeah.
A lot of times it was basically a second-year resident was in charge and a first-year resident was learning, and you'd have one second-year resident and two first-year residents, and there might be no attending. And in which case, it was like we weren't even, it was not great. And then, or a lot of times there was an attending during workday hours, like from 9 to 4.
Yeah.
But at night there wasn't. And then they said, hey, let's just have some of these fellows who might want to moonlight and make some money and sign off on the charts, just be there overnight if they want to. But it was, it's basically the residents handling everything.
Yeah. Unless obviously something surgical like open globes come in, which I imagine you get a lot of those.
There were a lot. And then the third-year resident gets woken up and to do something. And then the fellow is taking care of staffing that, essentially. So
things have
how about your residency?
Things have changed a bit. Well,
what was yours like?
Yeah, so I went to Iowa, and we didn't have our own eye hospital, but we just had a massive catchment area, right? Yes. So the Midwest, everything's so spread out. So we had 4 different states. We got South Dakota, Nebraska, some parts of Nebraska. What else is around there? Some southern Minnesota?
My home state
North
of Illinois
Dakota.
is not that far.
Illinois, yeah. So
Missouri,
just so many pages. So we got a ton of trauma. Farmers. Things happen on the farm. So and so we were the most challenging part about it though was it was home call. So it was basically an excuse to make us work clinic the next day after our call shift, because we technically, for some of those hours, we weren't in the hospital, even if we weren't able to sleep because we were fielding phone calls from patients and stuff.
Right.
And so not that they were trying to be malignant and make us work. It just so happened that we'd be on call overnight, and even if we didn't get much sleep, we would be in clinic all day the next day, which was a bit brutal. But it was a great learning experience. And as you mentioned, honestly, we probably should have just had our own eye, because I still have nightmares of looking at the ED board, and it's 6 or 7 eye problem. And when you have access to residents, right, what's going to happen? You're going to get called about any eye problem that comes in. And so it's a great learning experience, but also makes for a very busy clinic. And what I didn't realize was it's just very different out in the community, so which is kind of where you're practicing right now, right? You have more of a community-based practice.
I'm in Western Mass, just a retina practice that's filled with bread and butter macular degeneration treatments. We're the only retina group around this western part of the state, and we draw from southern New Hampshire and southern Vermont. But so we're doing tons of retinal detachments and the basic surgical stuff. But of course, as you know, retina practices are full of just injection clinics, essentially, for people getting anti-VEGF or drugs like Avastin, Lucentis, Eylea, Vabysmo now for not only
That's right.
macular degeneration, but also vein occlusions associated with macular edema or diabetic retinopathy. So, obviously we're thrilled to have these medicines. I'm not so old that I don't remember what it was like before we had them. It was really sad when someone would come with wet macular degeneration and you tell them, "I'm going.
Nothing
you're
you
going to
can
go.
do.
You're yeah. I'll see you in 6 months. I'm so sorry. There's nothing we can do.
Yeah.
So
How does it make you feel to think of getting an injection in your eye?
Not great. I'm not a fan of that idea. No.
I'm sure there's probably a big part of your job, because I can send all these patients, to I did a lot of injections in residency, but now we work with retina specialists in our practice, and so it all goes to them. I'm sure there's a lot of hand holding involved in telling patients it's going to be okay. That doesn't hurt as much as you think an injection in the eyeball is going to do.
It's a lot. It's not a lot of fun. None of us would want to do it, right? I mean, I had my students will watch me, and it's horrific to watch it, but in reality, it's actually so routine for us, and of course they get used to it, and they're so grateful to not go blind with that eye, or with sometimes both eyes. Quite commonly, we treat both eyes. So, and it's to the point where I'm doing it many dozens of times a day, and I tell my staff I've just done it like many, many times. Nobody in our office is screaming, it's going to be okay. It'll be over before you know it. And that's all true.
So since we're on the topic of, we've been talking about emergency type stuff, let's help clear up some things for for my non-ophthalmology, healthcare professionals out there, because feel like there's a lot of confusion around flashes and floaters, and retinal tears, retinal detachments, on how quickly they need to go to surgery.
Yeah.
So what's the latest? What's the latest for
I generally say,
let's hear it.
I would tell people it's very common to get flashes and floaters, but very uncommon to get a retinal tear, which can lead to a retinal detachment, which might need a procedure like surgery. So for those who aren't in retina, as you know, the retina is a lining inside the eye. There's a vitreous jelly in the eye that's very clear when you're young, but as we get older, it starts to shrink, liquefy, and pull away from the back of the eye. And because it's sticky, it can tug on the retina. And when it tugs on the retina, it can cause a flash sensation. Doesn't mean there's a tear, but it makes you concerned a little bit that maybe I need an eye exam. Little collagen fibers within the vitreous jelly become opaque. They cast shadows in your retina, which you perceive as a floater. Also, frankly, harmless, but sometimes if you get a whole lot of them, it can be indicative of this process where the jelly is separating from the retina, that process starting. So, generally, people are can just see their their comprehensive ophthalmologist or even an optometrist for flashes and floaters, and the vast majority of those people will find nothing will be wrong.
Right.
If that doctor sees something concerning, like blood in the eye or a few specks of red blood cells, or certainly a retinal tear, then they send them to a retina specialist. And if it's just a tear before a detachment occurs, then you can just do an office laser, and that's very easy. Sometimes, if you're unlucky, fluid can get through the tear under the retina, start to rip the wallpaper off the wall, for example, and then you have a detachment, and then you get a black shade that comes across the vision. But flashes and floaters generally aren't an emergency where you necessarily absolutely have to go the same day. I think within a week to see a provider is fine.
See, and I guarantee you that's different than what's being taught for most emergency.
I think it's more urgent or something like that.
Yeah. Oh yeah. Yeah. And so I think that's a problem we have in ophthalmology, is the disconnect between us and other specialties that do see eye problems. Flashes and floaters definitely feels more emergent, I would say, than it actually is to other fields. So, what about a retinal detachment? Let's say the emergency department, because they do their ultrasound. They're pretty good at it. They're pretty good at ocular ultrasound. They see something. They're pretty convinced it's a retinal tear retinal detachment. Okay. What does the data tell us about how quickly a retinal detachment needs to be operated on?
So, the vast majority, just in case now I'm worried that everybody's generally thinking retina stuff because it's so, they're not familiar with it. Their instant reaction is to hurry up and do something. the vast majority of times, this does not have to be seen that same night. Okay. So sending the next day to a retina specialist is perfectly acceptable and fine. As you and the audience may know, there's a difference in our minds between what's called a macula on detachment and a macula off detachment, wherein the macula being the center of the retina is what we use to see straight ahead. It subserves central vision. It's very valuable, very precious. A lot of times, frankly, patients don't realize they have a detachment until the macula is unfortunately detached. If the macula is detached and the center is totally dark, that actually makes it a much less urgent situation because kind of the horse is out of the barn. So we generally fix those within days. If the macula is attached, however, we generally want to try to do it sooner. And generally within a day is fine. If I see someone with a macula on detachment, I might do something in the office, frankly. If the detachment and the tear that caused it are in the upper hemisphere, then I can just do an office bubble. That's very common now. But if it's somewhere else and needs surgery, we'll just do it the next day, essentially.
You have any follow-up questions?
Well, that just, I'm barely following the conversation here, but.
I'm sorry. There are a lot of comments, but most people are asking people at cocktail parties about LASIK surgery. Should I get LASIK surgery? There's a lot of ophthalmology
I know, there is
questions and stuff like that.
Yeah.
Cocktail party questions.
I'm just thinking like from the patient perspective, if you tell me I have, a macula issue, I'm like, well, fix it right now, please.
Yeah.
Like to me as a patient, that would feel really urgent because like you could tell me the logic of like it's probably fine to wait up to a day, but I'm just thinking yes, but every moment we wait is another opportunity for it to get worse or be irreparable. So that I don't know what you tell patients like that because
that the photoreceptors are hanging on for dear life.
Yeah,
they're just waiting to be reattached to their underlying choroid.
Yeah.
I don't know. I think part of it I'm sure that there have been studies they have looked at like timing of like how quickly you can you need to restore the retina to its normal location, but also it can be tough to like it's such specialized surgery. It can be really tough to mobilize that in the middle of the night, or after hours, especially if you're out in the community. It's just not always a possibility to do it like right then and there, at least do it like a safe surgery. So I don't know. Maybe
generally it's very, very rare for me to be operating at night. I think that it's probably true that the concern that the general practitioner out there, emergency room doctor, has about like the urgency of it is probably it's not as urgent as people think at first thought. Yeah.
Well, let's take a quick break, and then we'll come back and talk about your book a little bit. Hey, Kristen.
What's up?
It'd be great to have
$1 million.
Sure, but also a little bit of disability insurance.
That would be.
We kind of dropped the ball on that.
Yeah, both of them, because you got testicular cancer twice and then had a cardiac arrest. And now you're basically uninsurable, but I love you anyway.
Yeah, it does make it a bit harder. And disability insurance is something that every physician needs to have.
It's true.
Because our job, our bodies and our ability to move our bodies are so important to the work we do.
That's right.
Well, let me tell you about Pearson Ravitz.
Tell me.
Yeah, this is a company founded by a physician, Dr. Stephanie Pearson, a disabled OBGYN who has now dedicated her career to helping physicians avoid similar oversight to, us.
Very important work.
Exactly. She's helped over 6,000 physicians get disability insurance. To find out more and get a free one-to-one consultation, go to Pearson Ravitz. That's PearsonRavitz.com/knock-knock. Again, that's www.pearsonravitz.com/knock-knock to get more information and protect your biggest investment, you. All right, we are back with Dr. Andrew Lam. Andrew, so I've read some of your book, Saving Sight, which right up my alley. Lots of eyeball stories. It's kind of your journey in learning surgery, learning ophthalmology, and also your upbringing. And one thing I really appreciate how you wrote it is you definitely wrote it in a way that anybody outside of medicine really can understand, because it's so complicated. like I can already tell, like some of the things we've talked about, Kristen is just her eyes just what?
Glaze over.
Well, part of that is because I've been listening to eyeball stuff I don't understand for about 20
Your whole
years now. So,
well, the people love it. Okay.
Okay.
Anyway, but you did a really great job in this book about trying to present these complex,
thank you.
not just talking about surgery as if everyone understands it, but really getting down into exactly what you're doing there. And so, tell us about your. I want to hear a little bit more about your upbringing, and
Sure.
I know that you were exposed to the world of surgery and medicine pretty early in life, right?
Yeah, I grew up in Central Illinois. My dad was an interventional cardiologist in Springfield, Illinois, and
He must have worked
it was
long hours.
He did. There were a lot of heart disease there, and I learned a few things from him. I saw how fulfilling like being a physician could be, but I also learned. I said to myself, if I'm going to be a physician, I'm not going to work this hard because we rarely had dinner together. He never came to watch my games, and he was a great dad, but he was just going in all the time to open up people's coronary arteries and stuff. So he had to do it. But I loved history actually more than anything else. So I studied history. I would have loved to kind of be a history professor, write history books and stuff. But it was his influence showing me like how fulfilling medicine could be that made me want to do medicine. And the book that you were kind enough to mention, Saving Sight, wasn't supposed to be about me at all. I had gotten this idea that, I had studied a lot about World War II in China during college. And when I was a resident at Wills, I actually said to myself, it's really a shame I can't share all this knowledge I have about what the Americans did in World War II in China with people. And so I said, I don't have time to write a nonfiction book, but I thought maybe I could write a novel because, I've seen every war movie ever made. And like I could dream up a romantic epic war story and use that as a way to convey this history that I love. And so I wrote this novel, I got a book agent. And then when you have a book agent, you spend all your time thinking, what else can I write about? Because now I have something very valuable, which is access to publishers and stuff.
Mm-hmm.
And I said, oh my God, I'm a very historically minded ophthalmology resident. I think these are stories about like Harold Ridley, who was this World War II ophthalmologist who basically invented the artificial lens we use in cataract surgery because he saw a downed fighter pilot with plexiglass in his eyes, or a doctor named Charles Kelman. Yeah, there's some amazing stories. A lot of them have to do with military history, which is my passion. And this guy named Charles Kelman, who invented phagoemulsification, which is how we take out cataracts. And he just had this epiphany when he went to the dentist's office and he was using this ultrasonic probe. And that's basically how we got our techniques. And I said to my agent, I got it. I got a great idea for my next book. It's going to be a book about ophthalmology's heroes. And there was like complete silence on the other side of the line. And she goes like, I'm sorry, I just don't think that's going to work. And I said, why not? I was crestfallen. And I said, these are amazing. And she's like, I just don't think people are going to buy a book about ophthalmological history, the general public. And after I thought about it, of course, she's right. Like, she doesn't want to waste time with a book that's not going to sell well. And I shouldn't waste my time writing a book that's not going to sell well. But I didn't want to give up on these stories. And then I thought, what can I do to make it more marketable? And I said, what if I brought the reader into the operating room to see what it's like when I'm trying to save sight or trying to learn, or more interestingly, what it's like when I'm coming up against a tough complication and frankly don't know what to do, or there's no good options. And I think that obviously is what made it a pretty successful book. And actually the Masters of Medicine, which is my newest book, it only came because people said, your Saving Sight book was great. It inspired me to go into medicine, or the stories were incredible. You should do that for all of medicine. And that's why that book came about, essentially, because we want to share how all these other fields have incredible unsung heroes who invented techniques and cures that we use today.
Just being able to relate to a general audience is such a valuable skill. And it is a skill because, we're, for our whole careers, are just so into all the medical jargon and terminology, and just being able to think outside of ourselves and relate these complex ideas is, I think we need more of that. Tell us a story from Saving Sight about. I want to hear about intraocular foreign bodies. So traumas.
Sure.
Happen.
Yeah.
Traumas happen. People.
I'm sure you saw some of those in your residency, right?
I've seen them. I saw a rather large BB That was an intraocular foreign body, which was the first time I saw a magnet. So I'd love for you to tell people about doing those.
Yeah,
types
I
of
actually
surgeries.
related a great story in Saving Sight about one of these incredible intraocular foreign bodies stories. When you have an intraocular foreign body, it's usually a situation where there was a high velocity piece of metal near the eye, often an auto mechanic or someone's grinding metal with no safety glasses. And so the patient comes in, and a ruptured globe is a very bad situation. The eye is like a squashed grape, basically. And if you come to a regular emergency room, they might not even see it because the eyelids are usually so swollen. They can't, they're not kind of confident enough to pry the eyelids open and press them against the orbital rim like we as ophthalmologists are. So you go there and you see telltale signs like chemosis, which is like a way the conjunctiva looks swollen, or just clearly like, a cornea that's been lacerated, and you do a CT scan and there's like metal in the eye. Yeah. So when you take them to surgery, your primary objective is to get the metal out and sew the eye shut. And that can be very challenging. There are definitely times when getting the magnet out, getting it out with a magnet is the best option. And there's a couple ways you can do that. There's a couple magnets we had in training where one is literally like some sort of, I think it was like a rare earth magnet where it was like the size of a shampoo bottle, and you could step on a pedal and it would activate. And I'm thinking like X-Men with the guy with the metal coming, the X-Men guy who with all the metal, literally it will draw whatever is in there very rapidly to the shampoo tip, right? And so if you're in a situation where like, there are definitely times when that's a useful thing, but it can be very abrupt and you have no control over that metal. Right. A more elegant way to do it is sometimes you have like a little stick, the end of a lollipop stick with no lollipop on it, and you can insert in the eye, and it's kind of always magnetized. And if you have your scope, like a biome that and can look at the retina, you can literally just bring it close and the metal will attach to it and you can draw it out of the eye. Except sometimes
you do.
There's I think I might go vasovagal in a minute. Ooh.
I know there's a lot of my kids might listen to this and they might faint. I don't know, but basically,
I think it's
the
great.
problem is the trauma is like there's never like a standard situation. The hole is never standard. The hole was not like you might make an incision, but it might not be big enough, and you might try to bring it out. The hole's not big enough. It falls back into the eye, and you're terrified. You just cratered the retina again because it fell into the back of the eye. And there's never it's always different. But those are satisfying to do because very few people can do it. But it's also requires a lot of empathy, obviously, because these are very traumatized eyes, and their prognosis is going to be very poor. So, how about you? Did you have any great stories where you saved eyes that you didn't? The best is when you do a ruptured globe, and then a year later you see the patient again. It's like, wow, the body is amazing. I didn't believe it could heal this well. I mean, did you have any of those good stories?
Yeah, I mean, I had a few. Traumatic open globes are almost always poor prognosis. Like it's just something that's some trauma that's bad enough to cause an open globe. It's generally not going to be a good thing. The best prognosis ones are actually often in kids or like young people. Like it's like something sharp, like a pencil or something. Mm-hmm. It just small little puncture wound. You can just go in. You can maybe it's like a self-sealing corneal lac.
Their vitreous in a young person is so formed. It's very forgiving in some ways.
Right. And so it does seem like the younger you are, and I don't know if there's any truth to this, but the younger you are, the more likely you are to be able to, maintain good vision. But I've had plenty of the opposite, where you kind of know, you're going to eventually have to just remove the eye. But you always try.
There are definitely times.
You always try. You always close up the eye to form it, and then and that's the classic teaching in ophthalmology is you never do what's called a primary enucleation, where bad trauma you just take out the eye, unless there's literally no eye to fix. You always try to fix it. You see what you're left with in terms of vision. Allow the patient, work with the patient to come to the conclusion that, okay, this eye is not going to see, or it's going to be painful for them to have the eye still, which is a common thing. what we call a blind, painful eye. No one wants to live like
Yeah.
that. And we can do amazing things with prosthetics now. And so,
Yes.
and so often it ends up with an enucleation. You're doing great, Kristen. You're
I'm
really,
just-
you're hanging
So
in there.
how about that
Yeah.
writing process, huh? Let's see.
But it's, there's one thing, I really appreciate having retina specialists in my practice, in part because sometimes I have to give you business that's my own fault. So, yeah. And so just in case there are trainees listening to this or are interested in this, and one of the most challenging things as a new surgeon is having complications.
Absolutely. We all have them.
We all have them. The only way to avoid complications is to not operate. And one of the complications that is probably one of the most common complications as a cataract surgeon is, remember I talked about the peanut M&M?
Mm-hmm.
Well, if you break the candy coating shell on the back end,
Mm-hmm.
then sometimes the lens can fall, the cataract can fall into the back of the eye, which is a place I dare not go as a cataract surgeon. And that's a complication. You don't want that bag, that
Right.
capsule bag, to break, because then you have to, all the vitreous, that jelly in the back of the eye, it starts to come forward. You have to clean that up, and then you can't fish out the little pieces of the cataract.
Yep.
So
Tell me more.
And I used to be like, so, I mean, it's obviously, it always sucks to like have a complication. And whenever, I was at the beginning of my career or as a resident, it always seemed like the end of the world. Like, oh my gosh, like this patient, I'm never going to be a practicing surgeon. I'm never going to have a successful career because I made this mistake. Or feeling like my retina colleague absolutely hates me because I'm giving them this really difficult, challenging job to do, cleaning up my mistake. And one thing I've learned in practice is that
no big deal. Yeah.
It's not a big deal.
No. So if there are cataract surgeons out there or residents, please drop lenses for a retina surgeon is no big deal. It's easy. We don't want you to touch. We don't want you to try to be a hero. Don't go into the vitreous cavity. Don't try to levitate anything. Basically, just put a stitch in your wound. And if you can put the lens in, that's great, because I don't want to have to put the lens in.
Right.
But it's very routine and easy for us to get the pieces out. And the patients often do extremely well.
And
that's not a bad one, to be honest. But I do know what it feels like to feel very bad that you messed up. I mean,
yes,
like that happened, and all residents have that experience.
Right. And that's the thing. Like, it's most of the time, it never ends up being as bad as you think it's going to be in your mind. And the eye can be very resilient, and they come back and they end up doing okay for the most part. So it's still, it doesn't feel good. But complications, like you said, they happen. I mean, I'm now, 10 years into my career, and dare I say you're a bit farther into your career than I am, just a little bit.
15 years out, maybe. Yeah.
Yeah. And things still happen, it's just a fact of practicing medicine. So anyway.
Well, everyone makes mistakes in their job. I think everybody can relate to that, no matter what your job is.
Yeah.
Thank you for saying that.
I mean, it's just true.
Yeah. Yeah.
Like,
sometimes you reply all on accident.
That's right. That
sometimes
does
you
happen.
thought you blind CC'd.
And sometimes it gets you fired.
Sometimes you drop the lens, and sometimes you,
insulted the CEO or something. Yeah, like it happens.
Sometimes you took someone's lunch out of the fridge, even though it said don't eat.
That's right.
But
I think sometimes we're our own worst enemy as physicians because we are so perfectionist, and we have trouble seeing.
I don't know how many times
faults.
I've had to remind you over the years that you are a human, in fact, and this is just a feature of being a human. It's not a bug. So
yeah. How was Andrew? How was your? What did your dad think whenever you decided to be an ophthalmologist?
And I think in his day, training in like the early 70s, the best and smartest went into medicine, right? Like the people who were dumb, quote unquote, went into surgery because they're just technicians. Like the smart cerebral people, they tell the joke, oh, if we want to stop the elevator doors from closing, I'm going to stick my hand between them. But you're a surgeon, you're going to stick your head between them because that's not the most important thing. Your hands are the only thing that matter to you. So, but then, as you know, medicine got much more lucrative for people who have procedures and people wanted to do surgery. And then people started wanting to have good lifestyles. And so like ophthalmology becomes popular, dermatology. I had the benefit of going to medical school and knowing a lot about different fields in medicine. And I think a lot of my classmates in med school thought they had to have a stethoscope around their neck to be a real doctor. I never felt that way. I knew there were other fields that I could really enjoy and love. And I really wanted to be a surgeon, but I wanted to have a pretty, good life that would allow me to do other things like, raise my kids or write books. And so that's been great. So I think that I'm sure he's happy for me that I do these things. I think he recognizes dads these days, unlike in his era, actually have to do stuff. Like the first diaper I saw him change was my kid's diaper. So, it's a totally different era. Right. So I think he's happy that I made a choice that was good for me.
Yeah.
That's all you can ask for. That's a good dad.
Right. Yeah. That's good. And you've practiced in so many different settings too. You did your internship in Hawaii, right?
That was great. Best year of my life. If you look at my life and I have 4 kids, I'd still go back to Hawaii. Just forget the kids, forget the books I've written since then. Like
was this pre-kids, right? Your internship?
Yes, after med school, transitional internship, class of 10 people every year at University of Hawaii. Probably the hardest thing I've ever gotten into, frankly.
Kristen knows all about the transitional years.
Why?
Poor residents, because I did one too.
Yes.
Poor residents these days don't know the magic of a transitional year.
Yeah.
They're doing integrated internships, so they're actually working.
It's changed. Yeah.
Yeah, I think you had maybe 2 rotations that year where you actually had like a real work schedule.
A real doctor schedule.
Yeah.
Was Hawaii
it was fantastic.
Oh my God. Which island were you on?
Well, we were on Oahu, which is where Honolulu is. And I mean, for me, I'm Asian American. I grew up in a place where there were very few Asian Americans. It's the first place I was ever in the majority.
Yeah.
And to be honest, that was just a totally different feeling. Like you don't realize you walk around all your life with like this on your shoulders, and then you realize, oh my God, this is how other people feel. This is how white people feel, basically. But at the same time, there's some things like, there were Caucasian people who were discriminated against in Hawaii because they were the minority. And I saw that happening, and I realized people are the same everywhere, all over the world, all time. So, but in addition to that, the training was good. They have a lot of really good people there, and it's the only med school in Hawaii, and of course they get incredible visiting professors, as you can imagine, who get their free trip to Hawaii. And there were a lot of great people, and there were some very unique situations. Like I'd worked in an ER in Philadelphia in med school, but I worked in the ER in Hawaii, and they're totally different problems, like sea urchin stings or going on an ambulance run to the beach to get a lot of the calls were for just elderly tourists who basically had chest pain on the beach, and we're trying to get these big wheelchairs or gurneys onto the sand, and you're on this. You look around, you're like, oh my God, I'm like an incredible beach. It's beautiful, and this poor guy's having a chest pain, and or because Hawaii is the only major like medical trauma center in the Pacific, you'd get calls from like islands, far-flung islands, there's this American island called Johnston Island, which is where we basically have studied and disposed of our chemical and nuclear weapons. And there's Americans there. And then some guy will be 5 hours away, and they'll be like, we're bringing in a guy with chest pain. We'll be there in 5 hours. We're getting on the plane from Johnston Atoll is the name of it. And it was just like bizarre because you're used to normally like chest pain coming in 15 minutes from a nearby neighborhood, right? So, but it was really great.
How much ophthalmology did you learn?
Yeah.
So many of people who are listening may not realize before you get to ophthalmology residency, you don't actually know how to see the retina or look in the eye very well.
Absolutely.
So
true.
my goal doing a one month rotation was just to be able to use the indirect ophthalmoscope to see the back of the eye. And I was able to do that, which put me a huge step ahead when I got to residency.
I'm about to say that was a huge step ahead because I couldn't even do that. That was, nor did I really make that concerted of an effort to be able to do that during my intern year. But that's the thing with the trainees now. You know, they're so far ahead of the game once they get to that first year of basically their second year of ophthalmology. They can already do so much with you know, being able to operate a slit lamp. And
I'm sorry.
What are you laughing at? What are you laughing at?
We're probably gonna have to cut this, but between all the eyeball talk and Milo's farting.
Oh yeah, our dog just ripped one.
Oh, nice.
It's so bad.
I thought we were doing you a favor talking about Hawaii now. That's not gross.
No, and then he had to ruin
I can't
it.
control your pets on your side of the screen.
Oh boy.
He knows what he did. Are you going to be all right?
Really struggling.
You're struggling
It's
today.
a tough one.
Like it's a little not seeing stars exactly, but a little funny.
We're almost there.
All right.
Are you ready? Are you okay?
Yep.
All right. Do you want to? Which direction do you want to go? Do you want another gross eyeball thing? Or maybe we can talk about his new book.
Let's do that.
You want to do that? All right.
That sounds safe.
Let's do that.
It's just eyeballs. I feel about eyeballs like he feels, and a lot of people feel about teeth. Like it's just a really squeamish area that I have. I can talk about other parts of the body a lot better than eyeballs.
Let's talk about your new book, The Masters of Medicine. So it sounds like you branched out into other areas of medicine with this, and
absolutely.
Is that right?
Yeah, after I wrote my book, Saving Sight, about the heroes of ophthalmology and all the incredible stories of perseverance, grit, and serendipity and lucky mistakes, that book was pretty successful. And people said, you should do that for all of medicine. And I was a kind of an arrogant ophthalmologist. I thought all the best stories of discovery were in our field. But I started reading about, during the pandemic, I had more time. I was kind of like one of these docs self-quarantining in a guest bedroom because we were seeing patients, as you all know, and many of your listeners I'm sure are familiar with. So I had time. I would binge watch TV and watch all The Walking Dead. And
I was
in the middle of...
Yes, I made TikToks.
You actually contributed to the world. I think I was in the middle.
Questionable. But yeah, thank you.
I was in the middle of Tiger King, and I thought, oh my God, I think I could do something more valuable with my time. So I started reading, and my dad was a cardiologist, so I started reading about cardiac history, and I was blown away. I'm like, oh my God, these are even better than the stories in ophthalmology. Like the guy who wanted to show it's possible to catheterize your heart through an arm vessel, Werner Forsman, in the 1920s, a German intern. And he just did it to himself and risked his own life.
What?
Or the people who invented basically open heart surgery to operate on beating hearts during World War II because they had soldiers whose chests had been blown apart with shrapnel or bomb blasts, and they were able to operate on them because there were pieces of metal embedded in the heart walls and lodged there, so they weren't dying instantly. Yeah. But they said we got to do something to save their lives, and that's how they started doing open heart beating heart surgery. And then they showed that they had success, and it showed that the heart was a viable surgical target. And then that led to the advent of the heart-lung machine and other inventions that made cardiac surgery an actual field. And I was just blown away. And then I said, I read about the discovery of insulin and how these Canadians, they invented this, they discovered insulin, but they hated each other so much that one of them almost refused his Nobel Prize just because he was so incensed that his partner was going to get one, because he thought his contribution so outshined this other guy's. And I realized these stories are basically human stories full of fallibility and envy and jealousy. And I was hooked. And I said, oh my God, we gotta write these stories of these medical heroes. And the book is separated into different important chapters that are diseases like heart disease, cancer, diabetes, trauma. And there's lots of incredible stories like how penicillin was discovered and how we actually credit the wrong person for discovering that. We credit Alexander Fleming, who discovered a lucky observation where there was a wayward mold that had fallen on his petri dish, and he saw that the bacteria around it were dead. But he didn't do anything with that. He just wrote a paper in the 1920s. And it wasn't until 10 years later that these British doctors from Oxford actually developed penicillin, did all the work for it. Howard Florey, Ernst Chain, Norman Heatley. And they were the ones who got the medicine penicillin, which was the wonder drug in World War II. And what happened was the journalists who went to interview Fleming and Florey, they found Florey to be very, very cool to them because Florey was very ethical. He's like, doctors should not do anything that would be self-aggrandizing or for publicity. So he wouldn't talk to them. Meanwhile, Fleming loved the attention.
He would have hated me.
he fit the picture of like this gray-haired genius old British doctor, and the journalist started just going to him and giving him all the credit and getting it wrong. And so every school kid knows Alexander Fleming, but he didn't really invent penicillin. So there's incredible stories like that. This rivalry between like Jonas Salk and Albert Sabin for the polio vaccine. There's just a lot of drama. So
I love the beefs.
Yeah.
It's great.
Some very nerdy beefs.
That's
good. Exactly.
That's just such a great idea for a book though. And I'm so like, what a lesson this is in combining two passions, right? That's something that I'm talking about. I talk about a lot with comedy and medicine. Yeah. Well, you're saying that you really had this thing for history. And so being able to, to work that into your career, I think is something that probably would help a lot of people to recognize that you can do in medicine. And it's something that's that thought gets kind of beaten out of us, right? That we don't, medicine has to be your life with nothing else around it. And I think it's cool that you kind of combine two passions.
Yeah, well, so are you. Both of you are doing the same thing and helping a lot of people. So
some
bring
people
a lot of mirth.
Some people do, valuable things during a pandemic, and some people watch Tiger King or make TikToks.
Yeah.
It's
takes all kinds.
It does. So people can find Masters of Medicine out now. Is it? It's
everywhere.
It's everywhere
Where books are sold.
Awesome.
Masters of Medicine. Yeah.
And you also have an Instagram. People can find you on Instagram at Andrew Lamb MD. Anything else?
My website's andrewlambmd.com.
Okay.
I'm on Facebook as well.
Great.
So,
how is your mental state with ophthalmology? Are you enthusiastic about the future? Are you how are you doing?
I mean, especially in our field, retina has so much research going into diabetic macular edema, macular degeneration, dry macular degeneration in particular. Obviously, there's a lot of companies that just want to get super rich with the next big thing, obviously. And in my practice, we're very involved with a lot of national clinical trials as well. And that's how a lot of developments occur. But obviously, you also have to kind of check your conflicts of interest and make sure, a lot of this is being profit driven, obviously. Yeah. But it's an exciting time to be in ophthalmology. And, a lot of people like doing research on ophthalmology conditions because it's easy to see the result. Like you can examine the eye, the inside of the eye, and see what the drugs are doing. Gene therapy, stem cells, those are all great kinds of place. The eye is a great place to test these kinds of things and get to see if you can get a good result, essentially.
That's awesome. Yeah, a lot of cool stuff in the retina world. I hear about it a little bit from the retina specialists that work with us, and you guys are really at the forefront of a lot of stuff that's going on. Just because you got a lot of diseases that we have good treatments, but still,
it's a pain to get injected every month.
A ways to go.
We're trying to make it better, make it last longer.
That's great.
They've tried a lot of different things.
Yeah. Well, thank you so much for joining us, Andrew. And it's just awesome to get to talk to you, and keep writing. I'm looking forward to what's the next book going to be, or is that just too painful to think about right now? Writing another book.
Yeah, I'm in a bit of a break now. So I learned also not to divulge projects that you think you can do, because sometimes it takes a long time. After my first novel, I wrote another novel, and I actually started talking about it in my book talks, but it took a long time to get a publisher, which is humbling. So it was many years later before my next novel came out. And so, but thanks for asking. Maybe there'll be something down the pike.
Yeah, no, don't put the cart before the horse, I think is what people talk about with that. All right. Well, thanks again. It's awesome talking to you.
Appreciate it. Thanks.
Hey, Kristen.
What?
You know what mites do when they get excited?
What?
They dance. They dance. They dance all over your face. You got these on your eyelids. You know that, right?
I do not.
Well, some people do.
Okay.
They're Demodex mites.
Yes.
They cause blepharitis, which is like red, itchy, irritated eyelids, like flakiness. Just want to scratch your eyes, and don't do that, by the way. But sometimes that's from disease.
Demodex dance.
It's the Demodex dance on the eyelids, except it's not that fun because it gives you all those symptoms. All right. So yeah, but they're cute, right? They're not.
Yeah.
They're not gross.
These ones are these stuffy
Yeah,
versions.
right. Oh, the
I don't
real
think
ones, not so much.
Are the real ones gross in the microscope?
They're still. I think they're still cute, but again, I'm an ophthalmologist.
Yeah.
But don't get freaked out by this.
Okay.
Get checked out.
All right.
All right. You go find out more. Go to eyelidcheck.com. Again, that's EYELID check.com to get more information about Demodex and Demodex blepharitis. I am so glad we did a dentistry episode and an ophthalmology centric episode relatively close together.
Yeah, we're recording those in the same day, and it's been a day. It's been a rough day. One for each of us.
Yeah, I mean, we got through it though. Like you said, during the dentistry episode, it's like exposure therapy.
Yeah.
It was so funny, like as he was describing, like using a magnet to pull metal out of an eyeball. I looked at you, and you looked like you were almost gone. Your brain was hanging on by a thread. You were trying to pass out, but you didn't.
I was starting to. What do you call it? It's not like stars, but kind of like
tunnel vision,
black and white. Yeah, maybe tunnel vision.
It was closing in.
Yeah, things were happening. Yeah,
you were struggling.
It was hard. Also, because I was in grad school, I did fMRI research, as you know, which is a gigantic magnet, an MRI machine.
Yeah,
and it just gets like pounded into you. No metal, right? Because it's a gigantic magnet, and if you have any metal on your body, it will just pull it out.
That's what you were imagining.
So yes, like that's just like my baseline for magnets on the body.
That's like third line therapy is just putting someone into an MRI and just letting it pull. No, out. We don't do that. We don't do that. All right.
It was rough.
I like hearing him talk about it. He's good at talking and telling stories. I like listening to him.
Yeah,
Dr.
I
Lamb.
could tell that you were very much enjoying yourself.
Super into it.
You love eyeballs.
Oh man, we gotta have him come back for Knock Knock Eye.
Yeah.
All right. Let us know, guys, what you think. We want to hear from you. Give us your guest ideas. Who have we not? What specialties in medicine have we not talked to yet?
Yeah. I mean, there's so many of them. There's got to be some that we haven't gotten to.
For sure.
So.
And so you can, lots of ways to hit us up. You can email us, knockknockhi@human-content.com. You can also hang out with us on all our social media platforms. Our Human Content Podcast family is on Instagram and TikTok @HumanContentPod. See all the offerings. I got some great stuff.
That's
great
right.
stuff. Thanks to all the listeners leaving wonderful feedback and reviews. We love those reviews. If you subscribe and comment on your favorite podcasting app or on YouTube, we can give you a shout out. Like on our YouTube channel @GlockenFleckens. We have @The Magnolia Witch about our 100th episode where we talked about old person smell. Remember that?
I do.
Said, what an episode to have post on my 40th birthday. Happy 100th, y'all. Appreciate
I feel your pain.
Yeah, I don't know if we decided what age it is that the chemical starts to
I don't think
secrete.
we did. No. Hopefully not 40. Do I have old person smell?
Not usually.
Not usually.
We also have a Patreon.
Great.
Lots of cool perks on our Patreon. Full video episodes up every week on our YouTube channel, by the way, @GlockenFleckens. Patreon, lots of cool perks. God damn, Milo.
Oh man.
Oh, it's been 2 days of this. Yeah, you know what you did. Look at me. Look at me. God, that was really...
You have no idea. No idea.
We have a Patreon. Lots of cool perks. Bonus episodes where we react to medical shows and movies.
Our dog.
You can hang out with other members of the community. We have early ad-free episode access, interactive Q&A live stream events. We have a lot more. We have dogs that are smelly. Patreon.com/Glockenflecken or go to Glockenflecken.com. Speaking of Patreon community perks. New member shout out Cassandra C, Evan C, Denise Z, my eyes are watering, Nicole G. Thank you all so much for being part of our
None of you deserve what's happening right now.
Shout out to the
Thank
Jonathans, as usual. Patrick Laciasi, Sharon S., Edward K., Stephen G., Marion W., Mr. Granddaddy, Caitlin C., Brianna L., Mary H., it's dissipating, K.L., Keith G., Jeremiah H., Parker, Muhammad L., David H. ×2, Kaylee A., Gabe, Gary M., Eric B., Marlene S. We don't have a lot of ventilation in this room. Scott M., Kelsey M., Dr. Hoover, Bubbly Salt, and, virtual RIP to Pink Macho, of course. Patreon roulette, random shout out to Amy. Amy, thank you for being a patron, and thank you all for listening. We are your hosts, Will and Kristen Flannery, also known as the Glock'em-Fleckens. Special thanks to our guest, Dr. Andrew Lamb, and to our horribly smelly dog, Milo. Our executive producers are Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brick. Editor, engineers, Jason Portiz. Our music is by Omer Ben-Zvi. To learn about Knock Knock High's program disclaimer, ethics policy, submission verification, and licensing terms and HIPAA release terms, you can go to, I got a headache now. You can go to glockandflecken.com or reach out to us, knockknockhigh@human-content.com with any questions, concerns, or fun medical puns. Knock Knock High is a human content production.
Why don't you crack a window? Knock, knock, goodbye.
Hey, Kristen.
Yeah.
What do you think about clinical documentation?
Boo.
You feel that strongly about it?
I do.
Why?
Because your doctor ends up spending all their time typing little notes on their little computer instead of listening to you or looking at you in the eyeballs.
Well, it sounds like your doctors could use DAX Copilot.
I bet they could.
Yeah, this is like a little Jonathan in your pocket.
Yeah.
It's an AI assistant that helps decrease the administrative burden that leads to burnout and leads to your doctors not being able to look at you while they're talking to you.
Yeah, it helps them do their little typing and take their little notes without having to do it themselves.
93% of patients say their physician is more personable and conversational with DAX Copilot. You love conversation.
I do, and I want them to be a person.
And that we need that because today's physicians are overwhelmed and burdened and they feel like work-life balance is unattainable.
That's right.
And we know that work-life balance makes you a better physician.
That's right.
To learn about how DAX Copilot can help you reduce burnout and restore the joy of practicing medicine, visit aka.ms/knockknockhigh. Again, that's aka.ms/knockknockhigh. Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.